again, I'm Anna Stein. I'm with the Division of Public Health. I'm an attorney. I'm also have a master in public health, background in health behavior and health education. I am from Winston-Salem originally, went to Spies and Brunson Elementaries, Wiley Junior High, and R.J. Reynolds High School. So I just wanted to throw that out there in case we have any other alums in the room or parents. So I have a lot of information to throw at you, so I apologize for everything I'm about to disengorge your way. But I know that this is in the paper every day. This is the news of the day, so I know that there's a lot of interest in this topic. So let me just forge ahead. So this is an interesting slide. It talks about the fact that deaths from overdose have now overtaken deaths from car crashes in the state, and also nationally. President Trump was, I think, talking about that a couple days ago when he was announcing the new plan from the Federal Commission on Opioids. I think there's something encouraging about this slide as well, and that's the fact that we were able to bring down those deaths from car crashes. That was not an accident. That was the result of a lot of folks in public health and industry putting their heads together to think about how to make that line go down. So, seatbelt laws and changes in the way roads are constructed and cars are constructed, that's why that line went down. And so we're going to be trying to make the opioid line go down as well. So when we're looking at what has caused these increases in overdose deaths, this slide really answers the question of what has caused these overdose deaths, at least until more recent years when we've seen more illicit drug deaths. But the answer is prescription drugs. That's what's caused our overdose deaths, because you can see an exact correlation between the increase in prescribing in prescription opioids that happened beginning around the 2000s and the deaths. They've tracked exactly. So also we know that prescribing varies by state. It's really a cultural thing. It's cultural within our prescriber communities. It's cultural within our patient communities in terms of what they expect. So that means that we have cultural changes to make in our state, because as you can see, North Carolina was one of the states with the highest rates of prescribing opioids in the country. And so this is a map that shows the rates of prescribing opioids by county matched up with the overdose death rates, and there's a very strong correlation between the amount of opioids prescribed and the overdose deaths. So this is something that we need to work on. So shifting to what is making people die today, we have the unprecedented availability of cheap heroin and fentanyl that is really driving our overdose epidemic currently. And I'll show you a slide next that really maps that change in the epidemic. But we know that the heroin is stronger. We have fentanyl. This is not the fentanyl that you would prescribe to a patient. This is illicitly manufactured fentanyl, oftentimes fentanyl analogs. They're changing one little part in the fentanyl in China, importing it so that it can be legally imported because it's not covered by any law. They'll change one little part of the formulation in order to be able to import it, and it's just really hard for lawmakers to change the laws fast enough to keep up with the drug formulations that are entering the country. And then, of course, you've got some carfentanil out there that's extremely potent. So this is a really important chart to explain what's happening. You can see that for many years at the beginning of this epidemic, so the early 2000s, and going up until fairly recently, it was really largely a prescription drug overdose epidemic. That has now shifted. Now more than half of the deaths that we are seeing are from illicit drugs. So, we just passed the STOP Act. I'm getting ready to talk about a lot of the interventions that we have going on around prescribing. And I will say that those are still really important, because even though we have seen the prescription drug deaths going down, and I do think that the prescribing rates are going down, but you can see that they're still much higher than they were in 1999. So we really need to continue to bring the prescription drug deaths down, and at the same time we need to address the deaths that are occurring from the illicit drugs. So what might the differences in responses be? When you're talking about illicit drugs, of course, there's much more of, it's going to be in the law enforcement, it's going to be in their corner about what they're doing to, you know, intercept heroin or intercept the fentanyl that's coming in from China or Mexico. And also, you look at things like harm reduction in terms of naloxone, getting that out into the community, and also treatment, people that are addicted to illicit drugs, how to get them into treatment. So that's how we in North Carolina have to think about our response to the epidemic in two ways: responding to the prescription drug side of it, but also the illicit drug side of this. So the demographics of who is overdosing, it's primarily late 20s on to middle age is the largest demographic that has been dying from opioids. It's primarily male. This is state data, overall state data, and then white. As far as I know, I do think this is changing somewhat and becoming more female, not majority female, but more female than it has been. And also I've heard that the rates are increasing among African Americans, at least in some pockets of North Carolina, unfortunately. So this is a map that breaks down the overdose deaths by region. So if you look at this just from a really broad, rough snapshot, you could say that the western part of our state looks like it has the worst problem with overdose death, followed by the eastern part of our state with the Piedmont in the middle, still having a lot of trouble, but not as much. But I will say that this rough map is it's misleading, because that western band of that Piedmont area is having a lot of problems. So look at the counties. This breaks it down by county, and you'll see a lot of your counties represented in this map that really weren't broken down in that Piedmont map. So really, the problem is starting in the western part of the Piedmont, going towards our mountains is where we really have a problem with the overdoses. So I wanted to let you guys know that we do have a website that's easy to find. Here's the URL, and you can get county data on deaths, hospitalizations, and ED visits broken down by county. And if you have any questions about this site, or if you want help analyzing data from your county, or a slide with data from your county, if you're giving a presentation, we have those. So my email is at the end of this slideshow, and you can email me, and I can put you in touch with our epidemiologists, and they're glad to give you the slides. So this slide we put in there just to show the possible impact that we have going on with our high school students. The fact that, so the youth risk behavioral survey is conducted every other year, so there'll be another one conducted this year. There was a slight increase of the use of prescription drugs from 2013 to 2015. To me, what's most interesting about the slide is what is not on the slide, and that is the use of heroin, because they used to ask about heroin use. I don't know when they stopped asking about it, but apparently the rates of heroin use had gone so low that the state felt like it no longer needed to ask that question on this survey. We now need to add the question back. So that's what, to me, is disturbing about this slide, is what is not on it. And I don't think we're going to be asking about heroin in 2017. So we're really missing some important data on what our high school students are doing. You can see there's been an extraordinary increase in the number of infants born with dependence to opioids. And so I know that our hospitals are struggling with that. We need to look at interventions to help pregnant women get substance use disorder treatment, and then of course the number of children entering the foster care system because they have a parent who is struggling with substance use disorder is ballooning. So we're just having an enormous impact on all of our social service systems. And this chart is just showing that deaths are the tip of the iceberg, and I was just touching on that. There's so many other systems that are impacted. Our hospitals, we've got the disease spread through injection drug use, law enforcement, criminal justice having to grapple with this problem, social services. So this is just an enormous problem for our state. So that kind of leads us to what do we want to do about this? So I'm going to go through some of the legislative and regulatory responses that we've had to this epidemic in the last few years and really delve in a pretty detailed manner into the STOP Act and what exactly is in the STOP Act, and talk about a few things that are coming down the road regulation-wise. So 4 years ago, in 2013, our state passed the Good Samaritan Law, and we were probably the first Southeast state to do this, one of the first in the country. I don't know how many of you are familiar with the North Carolina Harm Reduction Coalition. It's a very active community nonprofit in our state that does advocacy work, and they were behind getting this law passed. Just this yesterday, they were talking about how Arizona is fighting the passage of a similar law. So I just thought that I was happy that North Carolina has this, proud that we have it. So what this does is that means that if someone calls for help for someone that's having an overdose, that they will have immunities for, it's a small amount, immunity for possession of a small amount of drugs, but it's some immunity to help people call. There's also immunity for if someone is intoxicated with alcohol, which can be really important, especially on our college campuses. So it also provides the civil and criminal immunity for administering naloxone to someone. And so that has been good for our first responders to feel comfortable carrying naloxone and administering naloxone when they find people overdosed in the community. And importantly, it also allowed healthcare practitioners to prescribe naloxone through the third-party prescribing. So they weren't prescribing naloxone to the person that was necessarily going to need it on themselves, because you can't administer it to yourself, so you could prescribe it to a family member of someone who is at risk for an overdose. And so that was an important step forward as well. And this map shows the number of reversals with naloxone that have been reported to the Harm Reduction Coalition for a 4-year period. And you might wonder why Guilford, Buncombe, and New Hanover have the most number of reversals, because are you thinking, wow, is there that big of a problem in Guilford? And the answer to that is because that's where harm reduction is located. They have employees that are based out of those counties, and so they are distributing the most amount of naloxone in those places, and so that's why you have the most number of reversals in those places. But of course, we know that our overdose problem is much more widespread than just those counties. But I do think there's something telling about this map, that if you do distribute the naloxone, you will have those reversals as well. So something that happened last summer was we had a law that allowed our state health director to sign a statewide standing order for naloxone. So this allows pharmacists to dispense naloxone to anyone who comes to ask for it who meets the criteria, which is basically just that they are at risk for an overdose or they know someone who is at risk for an overdose. So very broad criteria on the statewide standing order for naloxone. And I'm going to go into that a little bit later. This is particularly exciting to me, and this is something that as a state we can be very proud of. First southeastern state to pass this law, so we legalized syringe exchange in the state. This was passed on the last day of the session with almost no fanfare. Again, this was the Harm Reduction Coalition slipping this in at the last minute. This was in direct response to the huge increase in hepatitis C costs to the state that I will talk about a little bit later, because I do want to delve into syringe exchanges a little bit more. So just to say, any governmental or non-governmental organization can start a syringe exchange. The law is very broad on who can start a syringe exchange. And the law it gives a lot of leeway on how this can be done. It does say that they have to provide access to referrals for naloxone and referrals for treatment. They have to give away the needles for free. Annual reporting to DHHS is required. It's not that complicated. The reporting is not complicated. It's meant to be a low barrier. And again, there are immunity provisions for a syringe exchange, just like we have in the Good Samaritan law, so that if the police stop someone with syringes that were obtained from a syringe exchange, they are not going to be charged with paraphernalia. And even if there's a small amount of residue, drug residue in those needles, they're not going to be charged for that residue. Okay, so here's the main event. The Strengthened Opioid Misuse Prevention Act, STOP Act, that was passed unanimously. How often does that happen? By both houses of the General Assembly in June, and then signed by the governor. So what does the STOP Act cover? And I will take a sip of water. So it specifically covers what it defines as targeted controlled substances. And that's just a definition that was created in the STOP Act. It's not like a federal definition, targeted controlled substances. So an earlier version of the STOP Act had included benzodiazepines as a targeted substance. And in fact, in other states that have laws similar to STOP Act, theirs would include benzodiazepines. For various political reasons, that got taken out. So now it is just Schedule II and Schedule III opioids. At some point, maybe benzodiazepines will be added back in. We'll see. So what does it do? So I'm going to break it down by the provisions for prescribers and then those for dispensers. So one of the major things it does is that it limits the first-time prescriptions of these targeted controlled substances for acute pain to 5 days or less. And acute pain is defined as pain that is expected to last for fewer than 3 months. So really, I think when we're thinking about this law, we have to think about what was the intent behind this law. And the intent behind this law was to prevent someone who I would say is opioid naive, who has some sort of accident or goes in for surgery, and for example, let's say a wisdom tooth extraction, or I think oftentimes for many people it's a dental procedure, and they go in and they get 30 days of pills. And the legislators were hearing these stories over and over and over again, and it seemed like everyone had a story of being prescribed way too many pills for some relatively simple procedure that they had had, and that they had tons of pills left over, and that those pills were just sitting in their medicine cabinet, and they didn't quite know what to do with them. It's inconvenient to try to get rid of them. So there was a sense, first of all, of not wanting to give this excessive amount of pills so that the person wouldn't themselves take all the pills that they really didn't need for that procedure, or that they wouldn't have so many pills left over in their medicine cabinet. So it was trying to right-size the amount of the prescription to the problem. And there have definitely been some studies, I think there will be more, but there's been some studies to show the amount of pills that patients actually take after certain surgical procedures. And people were taking definitely less than half of the pills that they were prescribed. I just think that study after study and anecdote after anecdote is showing that there's just way too many pills prescribed for these sort of acute pain situations. And so I just want to say that was the thinking behind this law. It really is not meant to address chronic pain as much. There are some provisions will impact chronic pain prescribing, but I'll say it's really kind of those first-time prescriptions for the opioid naive people to make the prescribers stop and think about how much they're prescribing. It also matches up with the CDC guidelines, which the CDC guidelines say that for most folks, 3 or fewer days is going to be enough for acute pain. And in fact, like New Jersey, their law that is like this law says 3 days. That is the strictest in the country. So anyway, the main legislator getting this passed, Representative Murphy out of Pitt County, is a surgeon. And so he changed the language to say that after a surgical procedure, you get 7 days. So you can see that, you know, there's a negotiation on how many days this was going to be. Now, the important thing about this, too, is that that doesn't mean that it's all the patient can get. If they need more than 5 days or they need more than 7 days, they can get it. It was really just trying to stop that knee-jerk prescribing of huge amounts of opioids for the less severe cases. So what happens, and I've got a slide on this a little bit later, but I'll go ahead and talk about this right now because the medical board has addressed this. So they've said it is not appropriate for prescribers to go ahead and give a second prescription right off the bat when they give the first prescription. They can't just say, well, you might need a little bit more. So I'm going to give you 5, and then I'm going to give you another, you know, whatever days because you might need more. They can't do that. But what they can do is if the person calls back in and says, you know, this 5 days is not enough, this 7 days is not enough, they can prescribe more at that point. At that point, they can prescribe the 30 days worth. There's no limitation at that point on what they can do. And so the medical board has said that the patient doesn't have to come in for another face-to-face appointment. It's enough for them to call the nurse line and say, I need more medication, and then the doctor can make that decision to give more. And so at that point, either the patient would come in and pick up that second prescription, or it could be e-prescribed. So there are ways that, you know, would allow this to be done in a relatively simple way if there were that e-prescription written and the patient wouldn't have to come back in at all. Okay, so this limit for prescribing does not apply to medications that are administered in hospitals, nursing homes, you know, hospices, residential care facilities, and also importantly, dispensers are not liable for dispensing a prescription that violates this limit. So it was important to the pharmacist that they not have to be the police people for this law, and whenever they get a prescription for 14 days or however many days, to have to think, oh gosh, do I have to call and find out if this was a first prescription for acute pain? So no, you know, the pharmacists are not the police for this, this provision, and it will be effective January 1st. So the other important thing that the STOP Act does is that it requires prescribers to check the controlled substance reporting system prior to prescribing targeted controlled substances, so that's just those Schedule 2 and 3 opioids, for the first time they prescribe it. And this would be for acute or chronic. This is just the first time that prescriber is prescribing that opioid. And then every 90 days thereafter if the prescription continues. And so this is where it is impacting that chronic pain treatment. And this also marries up with the CDC guidelines. The CDC guidelines do recommend that prescribers check their state PDMP the first time they prescribe and then every 3 months thereafter. So they have to review the patient information for the past 12 months. They have to document that CSRS check in the medical record. And it's not required, again, for those substances that are going to be directly administered in those inpatient type settings. And it's not required for substances that are prescribed for hospice or palliative care or the treatment of cancer pain. Although it could be a good idea to check CSRS in those cases, but the law is not going to require it. And then, so the DHHS is supposed to come up with a system to conduct audits of the review of CSRS by prescribers. So they are able in their system to tell if a prescriber checks CSRS in conjunction with a prescription that's then filled in their name. And they're going to come up with an audit system. I saw that Alex Asbin from CSRS is going to be here this afternoon speaking, so if you have any questions about that, you can ask Alex. And in terms of effective date, it's not clear when this is going to be effective, and that's, again, another great question for Alex. From what I've heard, probably sometime in 2018, maybe mid-year, but there's certain improvements that they're trying to make in how CSRS operates, and I do think when this becomes effective, there will be some really nice improvements in this being integrated into electronic medical records, and also the picture that the prescriber or dispenser would get when they pull up CSRS. It will give them some nice usable information in a way that may not be there now when there's just a list of the medications that the person has gotten. And so there will be more usable information. So I'm hoping that with the improvements that we're going to see in the CSRS, this would be the direction that prescribers and dispensers would be moving anyway to use this very valuable tool. But we're having this law to kind of enforce what probably a lot of practitioners would be doing anyway to give good medical care. Okay, so I've heard that there are PAs and NPs in the room, and this was a very controversial part of the STOP Act, was one of the later added provisions. And this requires PAs and NPs treating patients in a pain clinic setting. And, I've got the actual language here. So it's if the patient is being treated by a facility that primarily engages in the treatment of pain by prescribing narcotic medications or advertises in any medium for any type of pain management services. So that's who is going to be covered by this. And prior to prescribing a targeted controlled substance, if it's expected to exceed a period of more than 30 days, or 30 days, so more than 30 days, they have to verify with their supervising physician that it's a medically appropriate prescription, and then they have to reconsult with the physician every 90 days if they're going to continue to prescribe that. That went into effect July 1, so very quick effective date for that provision, and I know that a lot of folks have been scrambling to try to understand what this means. And so the medical board has come up with a new proposed rule, and this will go out for public comment. But it says that for the purposes of this law, the term consult shall mean a meaningful communication, either in person or electronically, between the physician assistant and supervising physician that's documented in the patient medical record. Meaningful shall mean an exchange of information sufficient for the supervising physician to make a determination that the prescription is medically indicated. Now, I don't know if y'all feel that this answers your questions about what this means. I'm sure there will still be a lot of questions about what this means, but they have tried to, make some explanation. It probably is helpful to know that it could be done electronically. That's probably helpful information to have. So again, this is not a final rule, but this is the proposed rule that the medical board has put out for comment. And you'll see this only references physician assistants, and so the nursing board is going to have to promulgate their own rule. There is a group of the medical board and nursing board that works together to make sure that their rules match up. I did ask if the nursing board has promulgated a similar rule, and the medical board said that they thought that the nursing board was working on it. So I would expect the same sort of language to be coming from the nursing board. Yes? I'm sorry, what? Right, so, okay, good question. So let's look at the statute. It says, would a family practice primarily engage in the treatment of pain? Would you say that would be the primary purpose of a family practice? Okay, so no. Would family practices advertise for pain management services? Then no, there's your answer. I mean, I'm not from the medical board, so I would say you could go verify that, but I mean, it doesn't fit the statute. So yeah, family practices, as long as you're not primarily engaging in the treatment of pain and you're not advertising that you do pain management, then you shouldn't be covered by this. So going on, more provisions for prescribers. So electronic prescribing of targeted controlled substances will be required beginning January 1st, 2020. I know that there's been some pushback from folks about, worried that they're not going to be able to get their software systems in time and the expense. I will say that there's a lot of public perception that this is a good idea. The report that came out from the Federal Commission, the President's Federal Commission on Opioids yesterday, particularly praises electronic prescribing as a response, says we need to have more electronic prescribing, praises North Carolina for passing this law. So I'll just say that I know that in some quarters people are worried about how do we comply with this? Are we going to have to outlay the money to get the system to be able to do this? But I would say politically there's a lot of support for this in the sense that people feeling like this is an important step that needs to be taken. Law enforcement has said that there is a good bit of stealing of prescription pads in the state. There's a good bit of forgery that's happening, and they are very supportive of this law. So what does this mean? There are some exceptions. So if the controlled substances are dispensed directly by the practitioner to the ultimate user, well, then you're not going to be writing a prescription. And then controlled substances that are administered in those inpatient settings, of course, they are not going to be doing electronic prescribing. And they have also excluded for now prescriptions written by veterinarians. There was a lot of pushback. Initially, this did include veterinarians. And there were some other, I think the CSRS check had applied to veterinarians. There were some ways that they were trying to include veterinarians, and the veterinarians did not like that, so they carved them out, but they have asked DHHS and the AG's office to get together and think about how all of this world should apply to veterinarians. So stay tuned for maybe some more laws or regulations affecting veterinarians. And again, trying to protect the pharmacists. So the pharmacists are not going to be required to verify that a prescriber falls into one of these exceptions. So if they are at the pharmacy and they get that paper prescription for a targeted controlled substance, it's not going to be their job to police it. That doesn't mean they can't question it if they want to, but the responsibility is not falling on the pharmacist to police this rule. Okay, so now moving to the provisions for dispensers. So it is requiring the dispensers to register to use the CSRS. Previously, there had been a law in place that had required prescribers to register, and it had been silent on dispensers. So now they're saying the dispensers have to register to use the CSRS. And then it's saying that they do need to check the CSRS if, and this is a subjective standard. So if they have reason to believe that the patient is seeking drugs for reasons other than treatment, or if there are other red flags, and it lists some of these red flags in the statute, like the patient is from outside this dispenser's geographic area, they pay in cash even though they have insurance, they're requesting early refills, they have multiple prescribers, they are requesting drugs by a specific name or color. So these are some of the red flags that would indicate that the dispenser should check the CSRS to see if there's anything that they can detect in the CSRS that might indicate a problem. If they are concerned about the fraudulent or duplicative prescriptions after they've checked the CSRS, they are required to contact the prescriber and verify that that was a legitimate prescription. So, but again, this law, I'll say, is very protective of the pharmacists. It says that failure to conduct a CSRS review does not constitute negligence. So I think that's a recognition of the fact that this is a subjective standard, that they don't want to do a lot of getting into pharmacists' minds about when they should have done what. But so failure to check is not going to constitute negligence, but I'm hopeful personally that, and I think a lot of pharmacists are hopeful, that this will spur a lot more checking of CSRS in cases where it should be being checked. So hopefully we'll have more checking. When does this go into effect? this does not go into effect when until those improvements are made to the CSRS. So again, mushy effective date, we don't know. You could ask Alex Asbin this afternoon to get an idea of when this might go into effect. So it does increase the frequency with which the pharmacies are supposed to be reporting, downloading that data to the CSRS. So previously, they were required to report within 3 days after the day it was dispensed. Now it's within 1 day after the day it's dispensed. And there's also a provision that is allowing DHHS to assess monetary penalties against pharmacies that don't give the correct data to CSRS after they have been told that there is missing or incomplete data. We did have a problem with pharmacies sending in missing or incomplete data and CSRS saying to them, this is missing, can you send in the new data? And they never did. So that's why this was passed. And apparently, I think I heard anecdotally this week that things have improved already, even though this hasn't gone into effect, because I think some of the chains are getting the headquarters involved and saying, what are our systems for responding to these requests from CSRS to get better data? So what needs to happen is the Commission for Mental Health, Developmental Disabilities, and Substance Abuse Services needs to pass rules that set forth the criteria for how to determine what the level of the penalty will be. They have not done that yet, and until they've done that, this is not going to go into effect as a practical matter. If you want to ask Alex Asbin what is the status of them passing those rules, you can. I do think Alex has been really busy with a lot of other things, so I don't know that this has been top on the list of priorities, but this will be something I think that will be looked at in the next year, and we will see. So there are also some really important harm reduction provisions in the STOP Act. So it allows community distribution of naloxone by agents of organizations that have a standing order to distribute. Just between you and me, Harm Reduction Coalition has been doing this for years. So this law, that wasn't technically kosher with the Board of Pharmacy, although the Board of Pharmacy said they weren't going to go out and start cracking down on Harm Reduction Coalition for doing these activities. But this law officially endorses the activities of Harm Reduction Coalition and says to other nonprofits or other organizations that want to do the same thing, go forth and distribute naloxone in your community. So what you would need is a standing order by a practitioner written to that organization allowing them to distribute. So it doesn't, so what you need is you need the prescription to get the naloxone to that organization in the first place. So that could be, there could be a standing order written by a medical director, or the organization could even obtain that naloxone through our statewide standing order. For example, some law enforcement agencies use the statewide standing order to purchase naloxone and get it. But then in order to distribute it, so not to use it on someone, like the law enforcement officers are using it on people in the community, but to actually hand it out to people in the community, you would then need another standing order written by like a medical director for EMS or a medical director for a health department or someone, Harm Reduction Coalition has a medical director. They are signing the standing order that says, go forth and distribute the naloxone. So that's how this is working. Another really important part of the STOP Act changed the language for the use of public funds to fund syringe exchanges. It now says you can't use state funds. So that means that local funds can be used, which is a really important step that allows counties, county commissioners, local health departments to fund the syringe exchange activities and to purchase needles, syringes, or injection supplies for those syringe exchanges. And that was effective this past summer. So some miscellaneous provisions. It's going to require in-home hospice providers to educate families about proper disposal. It's going to require certain reporting. Like I said before, the medical board has given some guidance about what the STOP Act means. This is the page that you can go to just to read that. I've covered what they've said about this 5 or 7 day prescription. If you have other questions, you can direct them to the medical board. The pharmacy board also has an FAQ on it. One thing I did want to share with you from the pharmacy board is that as a condition of license renewal for 2018, all pharmacists are going to have to attest that either they have registered to use CSRS or they have applied to register. Because they were saying that sometimes it takes a while for that registration to be processed. So you have to attest that you have at least applied, or if you're employed in a practice setting that doesn't dispense those Schedule 2, 3, 4 controlled substances, or if you're not in a North Carolina-based facility, or you're not dispensing to North Carolina residents, you are excluded from this. But if you don't fit in one of those categories, you will have to attest that you have registered. And I will say that this guidance document also has a link to free continuing education done by the Eshelman School of Pharmacy on using CSRS in case-based scenarios on how to use CSRS if you want to delve more into how to use CSRS in your practice. So there are new Medicaid rules for opioids that I wanted to cover. So beginning on May 1st of this year, the refill threshold for all opioids and benzodiazepines increased from 75% to 85%. Then beginning in August, prior approval is required for opioid doses that exceed 120 MMEs, are greater than a 14-day supply, or for any non-preferred opioid products. And the length of the prior authorization will be 6 months. There is a pharmacists can dispense a 72-hour emergency supply that's required by federal law. So you might have been running into some, I know when this went into effect, we had a lot of discussion from prescribers not liking that 14-day limit and having to work to get the prior authorization. I think maybe that's passed, maybe the outcry has passed a little bit for now, but I know that that was a hard pill to swallow at first. Oh, I do want to, while I'm on this topic of Medicaid rules, beginning on Wednesday, so 2 days ago, Medicaid took away its prior authorization requirement for buprenorphine. So that's a huge change that we've had with our prior authorization rules. And it's also said that prescribers cannot prescribe the monoproduct of buprenorphine to patients unless they are pregnant or they're somehow contraindicated to have naloxone. So they're going to be needing to prescribe that dual buprenorphine naloxone formulation of the MAT unless there's some particular reason that they cannot. I know that the mono product is much cheaper, but if it's covered by Medicaid, then that shouldn't be a problem for folks prescribing the dual product. I also wanted just to let you know that our industrial commission is working on some opioid prescribing rules that will cover workers' compensation claimants. That task force has been meeting since April. I'm sitting on that task force. I meet about 3 to 6 hours a week on these rules. We are being guided by physicians and nurses in these rules. Nobody's sitting around coming up with these that doesn't have clinical experience, but it's really trying to, the goal is to keep people, trying to put some stops in place, just some bumps in the road in place so that there's thoughtful prescribing happening. No one is going to be prevented from getting basically any opioid dose that the prescriber thinks that the person needs. That's not going to be prevented, but there's just going to be a few bumps in the road to make sure that folks are thinking. For example, right now there's talk of like needing prior authorization to go above 90 MMEs for certain levels of treatment. So that's the type of thing we're looking at. Of course, none of this is final. It's like far from final, but I just wanted to put that out there to let you know. I think the goal is to have a proposed version of those rules done in about 2 weeks that we would put out. I think we're planning to have a public meeting in December where people can come and give comments on those rules, and then the legislature would vote on them, I believe, in April. So they have been fast-tracked to go into effect possibly in May, is how that will work. So I did want to cover, so 5 minutes. I'm going to quickly cover just some of the work that the state has done, that DHHS is working on. We have an opioid action plan that if you Google 2017 opioid action plan, DHHS, you should find a copy of this action plan. There are 7 different focus areas to have a coordinated infrastructure, to reduce the oversupply of prescription opioids, which we've been talking about extensively this morning, reducing the diversion of prescription drugs and the flow of illicit drugs, increasing community awareness and prevention, making naloxone widely available, and then linking those overdose survivors to care, expanding treatment and recovery-oriented systems of care, and then to measure impact and change based on what we find. There are many, many different organizations. This is not an exhaustive list, but lots of folks coming together to work on this issue. And there is a group called the Opioid and Prescription Drug Abuse Advisory Committee. It meets quarterly. These are the folks that come together quarterly to talk about this issue. We have a web page, so if you want to go to that web page, you can see when the meetings are, the agendas. We meet in Raleigh, and we are meeting in December. I think it's the 15th is our next meeting. These are great meetings and great places to network. So if you want to see who are the really active players working on this issue in North Carolina, come to one of our PDAC meetings, or OPDAC. The legislature changed their name. So this is a breakdown of some of, I call them buckets, and the buckets that we're working on for our opioid action plan. And there are work groups in our OPDAC group for each of these sections. So there's a first responder work group, first responder and law enforcement work group. There is a community activity and prevention work group. There is a healthcare work group that I'm helping lead up. There is a treatment and recovery work group, and then there's a data and research work group. So what are some of the things that we're working on? Safe prescribing, improving pain management, CSRS issues, care linkages. That's just my committee. We have a payers council. The first time we're meeting is December 5th. We are bringing together all of the insurers in North Carolina, Medicaid, Blue Cross Blue Shield, United, TRICARE, VA, Cherokee Indians. We're bringing together every insurer that we could think of in North Carolina to look at what insurers can do to prevent overdose. So I'm really excited about that. Deeper dive into the syringe exchange that I promised. So this is why we passed that law. You can see this enormous increase in the number of Hep C cases that North Carolina has experienced in the last 6 years. It's an extraordinary increase in the number of cases. And then look at the Medicaid expenditures for Hep C, increased from $3.8 million to $85.6 million in 5 years. And that's because of the new treatment for Hep C that was so expensive. So you have the increase in cases coupled with the fact that it was now able to be treated, but quite expensively. So that's why in this conservative state, we were able to pass a syringe exchange law on the last day of the session a year ago. And also, of course, I just wanted to mention the fact that we've had a huge increase in endocarditis and sepsis. So that's another thing that the syringe exchange is trying to get at and decrease. So we are promoting syringe exchange as an intervention that really starts a conversation. So it's important to understand that syringe exchanges are not a way to glorify drug use. Or to enable it even. Syringe exchanges are an evidence-based method to get people into treatment, to develop those relationships in the field with people that use drugs, to get testing for communicable diseases, to help to prevent communicable diseases with the clean needles, and also just education about safe injecting and condom use. And so they're just evidence-based ways to decrease disease and to try to get people into treatment. And we have a Safer Syringe initiative at DPH, so we have a really great website. I encourage you to go to this website to learn everything that you want to know about our Safer Syringe initiative. And again, feel free to contact me if you want any more information on syringe exchange. Here is a map with the counties that we have served by syringe exchange programs as of September. There are multiple health departments that are putting syringe exchanges in their health departments. Right now, the Harm Reduction Coalition runs most of our syringe exchanges. This is an exciting thing to me. So Tripp Winslow, who works at Baptist Hospital, he is the director, the medical director of EMS for the state. He has this great idea of operating syringe exchanges out of ambulances and out of EMS services. So that's something that Tripp would like to expand throughout North Carolina. Yes?
No, I'm not Brad. I have a question. If the goal of the state is pro-treatment, why is the state pushing the methadone rules on the buprenorphine, making it more burdensome and less likely that people who are addicted to opiates will avail themselves of the most effective treatment for opiate dependence? I find that disingenuous in the extreme. And I find as a representative of the state, you simply have to take the heat for that.
I love to hear things like that. Absolutely. So I would.
And it's a very bad move, and it's a very bad policy.
Okay.
It's contra-therapeutic.
I would like to hear more about that. So let me get through these slides, and if we don't have other questions, I want to hear more about the methadone policy, or I'd like to talk about that with you privately if we run out of time with this group. So, and I also really wanted to point out that the North Carolina Board of Pharmacy has put out a statement that under North Carolina law, pharmacists are allowed to sell syringes to anyone without a prescription, and that the best public health decision is to sell syringes regardless of their intended use. And I have heard anecdotes from pharmacists saying that they were the only one of their colleagues that would sell syringes to drug users. And from a health department perspective, I want to encourage the sale of syringes to all people. You will not get into legal trouble for selling syringes to someone that then goes, that uses those syringes to inject them. Of course, that is your choice, but from a public health perspective, the best thing that you can do to prevent disease is to sell syringes to people, to sell clean syringes, because not selling the syringe to the person is not going to prevent them from using the drug. It means they're going to use the drug with dirty syringes and possibly spread disease. So we really need to have the clean syringes available and to have them sold by pharmacists. Okay, so another little deeper dive into naloxone prescribing and dispensing. There are a couple of parts in our action plan that regard that. So there is an intent to encourage naloxone co-prescribing by our prescribers when they're prescribing opioids to think about, is this person a candidate for a naloxone co-prescription? Are they on higher doses of opioids? For example, higher than 50 MME is the level that the CDC has pointed out. Are they getting another prescription for benzodiazepines? Even if you're not giving the prescription for benzodiazepines, when you checked CSRS, did you see that someone else is? Make sure that person has naloxone if they've got that dual prescription. Do they have a history of substance use disorder? There are just a lot of factors that play into when you might want to co-prescribe naloxone. And there are groups that are working on getting education out on when you should be co-prescribing naloxone. And then, of course, the pharmacist naloxone dispensing with the statewide standing order, there is that ability of pharmacists to be initiating these conversations. If pharmacists notice that the person has those same sorts of risk factors and that the prescriber did not co-prescribe naloxone, that's a great opportunity for the pharmacist to have those discussions and make sure that the person has the naloxone on hand. So what are we doing about that? There is a naloxonesaves.org website that the majority of our chains are signed up under the statewide standing order. A lot of community pharmacies are as well. Here is a map of all of the pharmacies locations. So we have very good coverage around the state, but if your pharmacy, for whatever reason, is not prescribing under the statewide standing order, sign up and let us know, and we will put you on the map. And that way, if a person in the public wants to go get naloxone in the standing order, your pharmacy will be listed. And the North Carolina Association of Pharmacists would like to increase the amount of co-prescribing that is happening. They have a free webinar, The Pharmacist and Naloxone, Opportunity to Save Lives, and that is on their website. Just go to the North Carolina Association of Pharmacists, and you can understand how to use this standing order. And I also wanted to point out some upcoming free webinars that they are developing. So they want to teach pharmacists how to use CSRS to provide intervention instead of just refusing to fill a prescription. So if you see that someone has a substance use problem, you're afraid that they have addiction, instead of just saying, I'm not going to fill that, what do you do to get that person into treatment? So these are the types of conversations that NCAP wants to train pharmacists to have. Also the fundamentals of pain management. What's a safe way to provide pain management? What about non-opioid pain management? Talking about needle exchange. There's talk about trying to start needle exchanges in pharmacies, particularly maybe in health department pharmacies, but also retail pharmacies. Permanent drug take-back boxes. How do you get a permanent drug take-back box in a retail pharmacy? We have some that are located in our hospitals right now, and that's great. That's a great start. But what if we had a permanent take-back box in every pharmacy? I know there are costs involved, but these are the sorts of discussions. I know that Walgreens has had some in our state, and then CVS just like a week ago has started to put in take-back boxes in various locations around the state. And then also, very importantly, medication-assisted treatment, and how can pharmacists pair with prescribers to help them assess how can we use pharmacists to the height of their licenses with all the skills that they have to help people get medication-assisted treatment and to serve as many people as we possibly can so they can pair with those prescribers who are prescribing the treatment, but the pharmacist can really help manage that. That would be optimal in our state. So NCAP is really trying to look at models of how that can happen and to try to get out the word about that. So that's really exciting. And I just also wanted to point out, for those of you who might not be aware, that the North Carolina Hospital Association has formed a coalition for model opioid practices in health systems. That group meets quarterly. There are 3 different groups. So there's one for prevention of overdose. So it's looking at really kind of the prescribing limit type stuff, the safe pain management. Then there's a group that's talking about what do we do if someone already has the addiction? What do we do for the drug-seeking behavior? So like I said, with NCAP saying, let's not just turn someone away from the pharmacy if they're coming in seeking drugs, let's try to get them to help. Same thing that the hospitals are looking at, let's not just treat the overdose and send the person out. Let's get that person into treatment right then and there. Let's start them on MAT in the hospital, possibly. Those are the types of things that are being looked at. Let's connect them. Let's do these warm handoffs. And then finally, there is a realization that healthcare worker diversion has been an issue for a long time, continues to be an issue. So not that North Carolina has an especially, I don't know that our problem is any worse than any other state, but the thought that while we had all the hospitals together, we would look at some of the mechanisms, make sure particularly that our rural hospitals had some of the knowledge and resources that our larger hospitals have been able to learn in terms of systems to track the flow of opioids around the hospital, and then also looking at the reporting that the hospital does to law enforcement or to the regulatory boards that our hospitals are meeting the expectations of law enforcement and the regulatory boards in terms of reporting to them. So that's another thing we're going to be looking at. So that's a lot. I've just thrown a lot at you. And now I want to have questions and discussion. Yes?
hospice patients? Because your slide said cancer pain was exempt.
Right. It did say palliative care, right? So again, I would say I'm gonna caution this to say that I don't want to presume to speak for the medical board because this would be, their call at the end of the day. As an attorney reading this law, I am willing to say that I believe that if care is being given by someone in a palliative care setting, opioids in a palliative care setting, that it doesn't specify that they have to be being used for pain management. I think the thought, you have to go back to why this was put in place. I think the thought, again, it was not to get those opioid naive people addicted. So when you're talking about someone at the very end of life in terms of the risk of overdose for that person, the risks are completely different. So that's why I would say that I would think it would be interpreted quite broadly in that palliative care setting.
And that includes patients in their homes.
Yeah. Yep. Yep. Any other questions? Discussions, thoughts? I love the comment back. Yes. I'm hearing grumbling. Are y'all saying, yes, you can? Yeah, it's interesting you say that because in our workers' comp rules that we've developed, okay. Well, I need to find out the answer to that question because in the workers' comp rules that we're proposing, we require that if the prescriber is prescribing an opioid and the person is already on a benzodiazepine, they have to contact the person that prescribed the benzodiazepine and tell them that they're starting to prescribe an opioid. So we are requiring that. So I now need to go to the medical board next week and get guidance on that. Yeah. Which will be nice when we get these rules out. Then folks can just kind of point to it and be like, yeah, we have to. Yeah, and I do, as much as I know that these rules and regulations can feel really burdensome to prescribers and dispensers, I have heard a silver lining of folks saying that it's nice to have it to show patients and say, I would love to prescribe you a big bottle of opioids, but I can't. I can only do 5 days because of this ridiculous Stop Act. So anyway, I do think that, and same thing with the, HIPAA or whatever, I do think it will be nice to get some clarification of these practices written down and the expectations of sharing that information, which will be critical. Any other questions? Yes.
I would thank you. I think it's great to come here as a lawyer and to present things that, are not your own, but you represent our state. So I really appreciate that.
You're welcome.
And I wanted to point out to the audience that our state has agreed that Narcan naloxone is a treatment, but it only works for an hour. And what Dr. Brown was saying, and what I would like to point out, is that we currently do not support buprenorphine. We have a single mono product, Suboxone Film. And I'm going to send y'all out a letter that I would like you to sign and send to our administration to say, we would like the state to support relapse prevention medicine. Because it's like giving insulin. If we only give insulin to somebody in a diabetic coma in the ER and send them out with nothing, they're going to go right back into that coma and come right back to it. So we need to support all treatments, not just one.
Are you referring to the fact that there's a preferred drug list for buprenorphine?
One product,
Suboxone? Yeah.
film.
Okay.
There
Okay, yeah. I've heard that concern from other people. And then I hear our pharmacy benefit manager from DMA explain the dollars and cents of why they have the rebates, blah, blah, blah. I know, it's hard. It's hard to hear the common sense. But, you know, change does happen. And so, you know, we had a lot of complaints about the prior authorization for MAT. We'd started these conversations with our pharmacy benefit manager, you know, earlier this year. He was thinking about it over the summer, mulling it over, and then Wednesday the change happened. Amen. Yeah, so, I mean, change does happen, and I will say there's a lot of issues. So with the naloxone, I've heard that folks are getting dinged in terms of prescribing Narcan because of their generic, non-generic ratio, and so they can't afford to prescribe naloxone under the standing order. So we're addressing that with DMA. Also, the 22 visit limit. You know, how are you going to be prescribing MAT with that 22 visit limit? Problems with the lock-in in terms of if folks are within one practice, if they want to go on vacation or if they want to have residents come in and be able to participate in that MAT program and write those prescriptions for MAT, that just adds another prescriber. You know, you're going to get up over that 3 prescriber limit pretty quickly. So we are hearing you. Keep the complaints coming. Email me. My email's in the slide deck. I do have those direct channels with our Medicaid folks. And I will say those folks have great hearts. They are working. They are having these financial issues that they're working with. So, but it's this constant grappling and this constant squeaky wheel. So we will keep trying. There are issues that need to be solved. But I need to hear from you guys because I will never come up with the stuff on my own. I can only, I like to hear from doctors and pharmacists and nurse practitioners and PAs. So let me know the problems. And I might be out of time. Yes, thank you very much. Oh, and yeah, this is there's my email.